Good evening, CCI. Today is Thursday evening, and it is time for our master class from one of our prolific speakers of CCI. I would like to start the introduction with this sloka. Guru Brahma, Guru Vishnu, Guru Deva Maheshwara, Guru Sakshat Parabrahma, Tasmai Sri Guruver Nama. So let us welcome our master for today's class on smoking cessation, Dr. K.S. Satish sir. Sir is a senior pulmonologist from Bangalore with rich experience, and Sir is working in the Department of Pulmonology and HIV Medicine, Fortis and Vikram Hospital, Bangalore. Sir has completed MD from BMC 1985, DNB 1986, and MRCP and FRCP from Royal College of London. Sir is also a member of Indian Academy of Allergy. Sir has been principal investigator for many global trials, and Sir's areas of interest include all the respiratory diseases. So it will be a very rich experience that Sir is going to share with us today on smoking cessation. Friends, as we all know that nicotine addiction is a curse to the mankind. Tobacco smoking leads not only to many respiratory diseases but also has systemic inflammation and effects. Patients become so dependent on smoking that they're not able to come out of the addiction even when they are willing to quit. So, as pulmonologists who understand the various effects of smoking and treat various diseases that ensue, we also have an obligation to help them quitting smoking. From pharmacological treatment to non-pharmacological methods, various options are available which have been tried, tested, and evaluated and have given varied outcomes. To enlighten us on all these various aspects of smoking cessation, I request Dr. K. Satish sir to start the session. Before that, I sincerely thank the National President, Dr. M. Narendra, who is my guru, Dr. Ravi Doshi, Dr. Narayana Pradeep, Dr. Chennam Shetty Vijay for giving me this opportunity. And I also thank and congratulate Dr. N.H. Krishna for this unique masterclass sessions for the CCI family. With this request, I uh, ask Dr. K. Satish sir to start the session. Sir, please start the session.
Good evening, everyone, and thank you, the organizers of this masterclass, and also my CCI for inviting me to speak on smoking cessation. I take this opportunity to thank everyone who is involved in making this, presentation. So, what I'm going to do in the next 30 minutes or so is to take you to forms of tobacco Indian scenario, second and third hand smoking, health consequences of smoking and tobacco dependence, nicotine, its distribution, its pharmacodynamics, and neurochemical effect. There are behavioral interventions, barriers, benefits, and strategies which I'm going to briefly touch upon. And then largely I'm speaking about pharmacotherapy for smoking cessation. And there are some government interventions which I will touch upon. And there are, about e-cigarettes and new molecules in pipeline and summarize everything. This is my flow of talk this evening. So let's see the forms of tobacco. So we are all familiar in India about the forms of tobacco use. Tobacco use is a major preventable cause of premature death and disease, and currently leading to more than 5 million deaths each year worldwide. In India, tobacco was introduced way back by Portuguese and British promoters to establish the tobacco industry in the country. There are different forms of tobacco. Smoking tobacco products include BDs, manufactured and hand rolled cigarettes, hookah, water pipes, and sticks, and so on. Smokeless tobacco products or spit tobacco include chewing of these tobacco products, such as betel quid with the tobacco, kaini gutka, pan masala, and Manipuri tobacco are all familiar to all of us. So Indian scenario of tobacco smoking is population age 15 years and above in thousands. If you see by by 2000 it was 353,000 men smoked, and women 331 um, thousand smoked, and both sexes together 685,000 smoked. By 2020, it almost doubled to 509,000 and in men and 484,000 in women, and both sexes together it comes to about 993,000. The projection for 2025 is that 543,000 men and 517 women, making a sum up of nearly 100 100,061 people who are going to smoke and use tobacco in India, which is a big concern for all of us because it's not coming down, it is increasing, and men and women contribute to the same. These are Indian scenario, fitted age specific groups and current smoking in 2000 and 2010. It's showing a similar pattern in men and women. These are age group. If you see the age group of 40 to 25, it starts from 25 age and goes up to 65, 69, and so on. Similarly, in women, it starts little later, 25 to 39, and goes up to 70 years. So the WHO global report on trends in tobacco smoking 2000-2025 estimates about 13% of Indian population smoked, and 24% were men and about 3% were women. And if the projection is right, and we're going to see an approximately 15% would be men and 1% would be women in India. Let's see what's happening to second-hand smoking and third-hand smoking, which is equally important. These are also called environmental tobacco smoke, involuntary smoking, and passive smoking. It is a complex mixture of chemical constituents and particulates released into the atmosphere from the burning tip of cigarette, pipe, or cigar, including the smoke by the smoker. Globally, it is estimated that about one third of adults and an estimated 700 million, children worldwide are exposed to second-hand tobacco smoke at home. What is third-hand smoke? Which we are not very familiar with this word. It refers to toxic chemicals built up for weeks and months from second-hand smoke, like coating the surfaces of room and smokers belongings. So it is there in the smoker's home and on the surfaces that they touch upon and use, maybe also in the office. I'm not going to be in detail describing about health consequences of smoking, since this topic is mainly on smoking cessation. Tobacco use has been regarded as a potential risk factor for most chronic conditions like cancer, cardiovascular, and pulmonary diseases with serious deleterious effects. increase in the cancer of the lung, we all know, chronic obstructive lung disease, which we deal day in and out, and cardiovascular diseases. Our colleagues in cardiology are all strongly associated with cigarette smoking that they see. Newer research findings indicate that smoking is a major risk factor for tuberculosis in India. This is really shocking and also a new development that the tuberculosis, India is one of the major country contributing to the world population of tuberculosis. That is, one third of the world's population of tuberculosis live in India. Smoking is a risk factor. Smoking in pregnancy increases chances of low birth weight, miscarriage, premature birth, sudden infant death syndrome. Also, smoking oxidative damage causes inflammation and causing, problems like cataracts and age-related macular degeneration, which occurs prematurely in these patients who smoke. And if you see here, uh, the the tobacco dependence, the International Classification of Disease (ICD-10) has recognized that tobacco dependence is a disease. Tobacco dependence is defined as, this is very important, a cluster of behavioral, cognitive, and physiological phenomena that develop after repeated tobacco use and that typically include a strong desire to use tobacco, difficulties in controlling its use, that is, not able to control its use, persistence in tobacco use despite harmful consequences. Patients do know about the harmful consequences, but they continue to use in spite of knowing this, and a higher priority given to tobacco use than other activities and obligations, increased tolerance, and sometimes a physical withdrawal state is defined as tobacco dependence. So what I'm saying in this slide is that tobacco dependence is a disease. It is not just a habit, it's a disease, and we must you know uh, treat this as a disease. Now let's see what nicotine does in terms of distribution, pharmacodynamics, and neurochemical, effect. So pharmacodynamic effects of nicotine on central nervous system, pleasure, arousal, enhanced vigilance, and improves task performance and anxiety relief once it gets absorbed into the blood circulation and travels to the brain. The cardiovascular system is equally affected. Increase in heart rate, increased cardiac output, increased blood pressure, coronary vasoconstriction, and cutaneous vasoconstriction are the effects of nicotine on the cardiovascular system. There are others like appetite suppression and increased metabolic rate and skeletal muscle relaxation. Now, the same thing said, like there are neurotransmitters and its effects by nicotine on the brain. So, nicotine induces variety of central nervous system, cardiovascular, and metabolic effects. It stimulates the release of many neurotransmitters, which have been associated with effects shown in this slide. This is important when we think and start discussing about the use of pharmacotherapy in smoking cessation. Neurotransmitters like dopamine, which causes pleasure, appetite suppression, norepinephrine, arousal, appetite suppression, acetylcholine, arousal, cognitive enhancement, glutamate, learning, memory enhancement, serotonin, mood modulation, appetite suppression, and beta endorphin reduces anxiety and tension, and GABA reduction of anxiety and tension. These are the effects of nicotine through these pathway of various neurotransmitter, dopamine being the most common. Who doesn't want to have this effects in day-to-day life, except that if it did not cause any of the side effects that it has on various serious side effects it has on the cardiovascular system, on the pulmonary system, and so on. Now let's see how we can change all this: behavioral interventions, smoking cessation, barriers, benefits, and strategies. Let's look into this. So there are two parts in this tobacco dependence. One, a physiological; second, a behavioral. The addiction to nicotine, leads to treatment and medication for cessation. Similarly, behavioral, the habit of using tobacco, that needs to be treated, and that leads to behavioral change program. Treatment should address the physiological and behavioral aspects of dependence. Each are interdependent. If you address only one, that is physiological, not good enough, the outcome. If you address only the behavioral, in some it may work, may not work in all. So it is interdependent and both are equally important. Now, tobacco cessation, is essential to reduce mortality and morbidity. And presently, India has about 18 tobacco cessation clinics, which are official, but all of us are doing in our own clinic and setups and in hospital. And this needs some, serious thought. Tobacco cessation methods can be broadly classified into cognitive behavior therapy, CBT, which includes methods such as self-help, brief intervention, which can be provided by health professionals, intensive therapy at smoking cessation centers, the pharmacological intervention, first and second line, and nicotine replacement therapy and antidepressants like bupropion and so on. So there are three of these broadly classified areas: cognitive behavioral therapy, intensive therapy, and pharmacological interventions. So let's get into some more details about behavioral interventions. We are all familiar with 5 A's to quit tobacco. Ask each patient to quit at every visit. Ask each patient advised to quit, tobacco at every visit, and assess each patient willingness to quit at every visit. Assist him in quitting within 2 weeks with pharmacotherapy and counseling. You arrange for follow-up contact in first week after quitting. If patient says yes, then you take the second part, that is 5 R's, to the patient who is unwilling to quit tobacco. If he says yes, that is one. If he says no, he's not willing, but you don't give up on this. Relevance, why quitting is important to them, explain to him. Risks involved, negative consequences of ongoing habit, what it can have on his health, and its indirect effect on the family. And rewards of benefits of tobacco cessation, explain to him. Roadblocks which are there, identify, and impediments to quitting, like weight gain, for example, withdrawal, for example, anxiety associated with all this, can be addressed to an unwilling patient. And repetition, repeat every time the patient come to the clinic. Don't give up, and don't say to a patient that if you give up smoking, then only I will see you next time. If you don't give up smoking, don't come back to me. This is the sentence many patients keep hearing. I didn't want to go back to my doctor because he said you quit smoking and come back. That is not the attitude that all of us should be doing. We should be uh, proactively counseling these patients to quit this habit. As I said, tobacco smoking is a disease. Now, there are some examples of behavioral interventions for nicotine dependence, like CBT, cognitive behavioral skills, self monitoring, behavior rehearsals, practicing self control over smoking triggers. Many patients say, I will try my best, I will come back to you. And that is good thing if they say that they will, come back to us, and I will try my best. This is what I want to hear from my patient, rather than a patient saying, I don't think I can do this, I cannot do this, I don't want to do this. But if somebody says that I want to come back, I want to try, and then let us see what happens. That is a good proactive kind of patient's attitude. Assertiveness in training to help smokers better handle their social situations, like trigger cues to smoking will help. Instructions and training, deep breathing, for example, yoga, mindfulness training will also help these patients in this cognitive behavioral skill training. Instructions on how to use medications properly, biofeed mechanism to help these patients, and facilitated discussion with a group of smokers to share effective behavior change experiences and challenges go a long way in making patients quit smoking. If there are self-help groups which are there, and they should be looking for one in their community. Motivational intervention, like for example, this method relies on counselors eliciting from the client their own motivational change rather than imposing treatment plan on the smoker. So you do this, rather than what you want to do and how do you want to come out of this habit, is the best method, rather than imposing on him you know a kind of treatment plan. Incentives are always good. I remember way back in UK we used to say, put all the money that you are spending or saving on smoking in a jar, and then see you how much you save for your family, for yourself, and maybe if you want to donate it to some charity, that is fine. Some motivation and incentives will help. Benefits with smoking cessation are the deleterious effects on systemic health gradually diminish over time. Risk of recurrent heart attacks and cardiovascular deaths are markedly reduced 50% or more after smoking cessation. Isn't it worth doing for all our patients? And blood pressure and pulse drops to normal. Risk of cancer of mouth, throat, esophagus, bladder, kidney, and pancreas goes down over time. Short-term benefits include a feeling of fresh air around a patient and in his environment. And it is said it's never too late to quit. Within 2 weeks of quitting tobacco, lung functions increase. Can you believe this? Lung functions start showing improvement. 10 years, the risk of lung cancer is half of that of a smoker. Barriers with smoking cessation: implementing tobacco use cessation counseling, participation in tobacco use cessation, clinicians as well as patients, effectiveness of tobacco use cessation counseling, addiction, weight gain, depression. All these are some of the barriers that we all face, and each one is important, each one is serious, and each one has to be addressed adequately. Now let's see some of the strategies for addressing these barriers. And I will briefly tell you, this is a busy slide, but I will just highlight a few of these taken from Barwan Rigotti in 2018. Providers, the barrier, providers lack of education, that we ourselves are not equipped, so that is why the strategy should be smoking cessation, treatment content and practice, opportunities in healthcare providers curriculum, including questions in cardiology exam, in pulmonology exam. This will make students, postgraduates, learn about it and give importance to smoking cessation strategies and methods, and annual updates and so on, like what we are doing now. Providers lack of time, this is one important thing. We all feel that we are all very busy treating patients, but we don't have time to spend with our patients about making them quit smoking, asking them about smoking. So in case you are too busy, do something like, for example, quit lines, or hire a dedicated smoking cessation counselor. Ask your junior to help, and make him aware of these strategies, and this will help. Barrier, smoking among healthcare providers is also a barrier, which fortunately I feel in our hospital at least it is less, but it is a barrier. Healthcare delivery system, smoking cessation is not an expected part of the care. This is another importance, but provide access to smoking cessation, modify the electronic health record to create alerts and clinician reminders to ensure that all patients who smoke receive treatment. In my proforma of respiratory system, there are 3 times I'm supposed to ask the patient about smoking. As soon as I start jotting down the history, and then about details about this, and later when he goes for a lung functions test, the smoking history is elicited. Recommend actions regarding second-hand smoking exposure. Routinely ask all patients, especially non-smokers, about their exposure to second-hand smoking. Many a time we have all faced a situation where we keep asking, "Have you been smoking?" Patient keeps saying no, and we feel that he is lying, but he's having second-hand smoke exposure, and that's where the problem lies, that we don't elicit. Inform patients about the SHS exposure increases the risk of cardiovascular events even in non-smokers. Advise all patients, especially non-smokers, to adopt a smoke-free policy for their home and car, and avoid other sites of SHS exposure. Actively support smoke-free policies at work sites. I'm sure you've seen your next smoking, place is 5 kilometers away in some, in some faraway places, and things like that, probably will help. Let's come to the important part of pharmacotherapy for smoking cessation. This is the scoring system which the Swedish clinician recommended, and which you I'm sure are all aware of it. Fagerström test for nicotine dependence. There are six simple questions. How soon, for example, after you wake up, do you smoke your first cigarette? Within 5 minutes? 6 to 30 minutes gets 2 points. 31 to 60 gets 1 point. After 60 minutes, 0 points. Similarly, do you find it difficult to refrain from smoking in places where it is forbidden, like church or library or a cinema or a train or a restaurant and so on? And he gets yes, 1 point, no, 0 point. Which cigarette would you hate the most to give up? How many cigarettes per day do you smoke? 10 or less, 0 point. 11 to 21, 21 to 32 points, and 31 or more, 3 points. Do you smoke more frequently during the first hours after waking than during the rest of the day? Yes, 1 point, no, 0 point. Do you smoke if you are so ill that you are in bed most of the day? Yes, 1 point, and no, 0 point. And the results you know, can be calculated. Score 0 to 3, low dependence, maybe benefited, maybe he will benefit from behavioral treatment. 4 to 6, moderate dependence. Score 7 to 10 is high dependence. This is a good score that I have found useful. You don't have to really by heart this, but you can keep it in your memory and keep asking this. So these are FDA approved smoking cessation medications. I won't go into the details of each one, but all of us have used this and know about it. Nicotine patch, for example, is a replacement of nicotine in the blood and taking away the patient's withdrawal side effects and craving. And uh, uh, and I use especially nicotine patch. There are three dosage: 7, 7, 14, and 21, which are really good. You start for somebody with low dependence 7, and then 14, and then 21. Starting doses for more than 10 cigarettes, like the Fagerstrom scoring system. More than 10 cigarettes, you can start with 21, and then 14, and then after 6 weeks to taper low to doses. Use for 3 months or more. After 6 weeks, continue original dose and taper to lower dose. These patches are applied, as you know, on the body surface area, and there are some minor side effects like local site irritation and so on, and sometimes trouble sleeping and so on. Most of it is attributed to withdrawal of nicotine. The advantages are throughout the day it provides the nicotine level, but combination of NRT therapy, like for example, this is a patch. So in between you can add, for example, add short acting NRT like gums, lozenges, inhaler, or a spray to the patch to cover for situational cravings. In between he has sudden craving, so chew a gum, chew or inhale or use a lozenges. This will really help. So nicotine lozenges come in 4 milligram and 2 milligram, and if first cigarette is less than 30 minutes of waking, chew 4 milligram, and similarly 2 milligram, and you can use for 3 months. And some minor side effects, non-specific, like mouth irritation, hiccups, heartburn, nausea occur. Nicotine gum, which used to be available, very frequently earlier, and now also it's available, 4 milligram and 2 milligram, and similar to nicotine lozenges, and it's all personal, preference. Nicotine inhalers are available. Nicotine nasal spray is available, and these are part of the nicotine replacement NRT treatment. And there are very minor non-specific side effects, but you can always change whenever patient feels it is troublesome. Okay, the next in the list is the vernicillin. I have extensive experience in using vernicillin. I like this product, less side effects and effective. Again, all this have to be combined with behavioral therapy. Then only the outcome is extremely good. And there is no point giving these medication without counseling the patient, talking about it, about the behavioral therapy. It may be your own behavioral therapy, or it may be a professional counselor behavioral therapy, which is important. It's available as zero point 0.5 milligram and 1 milligram, easily recognizable, easily identifiable packs for patients. Very easy. I like the packet. So day 1 to 3.5 milligram per day. There is only one tablet to be swallowed, and the night tablet there is a gap or empty slot, and from 4 to 7 it becomes twice a day, zero point 0.5 milligram, you can see on the package. And from 8 day onwards, 1 milligram twice a day, identified by change in the color of the tablet, and used for 3 to 6 months. Many a time patients come back and say, oh, I'm doing good after 2 to 4 weeks, but relapses are very common, very frequent. Start 1 to 4 weeks before the quit date. This is important. Don't ask the patient to start now and then quit tomorrow. Yes, you can do that, but Start before the quit date. Always have the patient record a quit date. So this will work, to the benefit of patient. Take with food and a tall glass of water to minimize nausea. So there are minor side effects like insomnia, vivid dreams, and headache I have found in some patients. And quit date can be flexible from 1 week to 3 months after starting the medication. This is important. Patient can even take few months before the before taking these medicines before the quit date, and it relieves nicotine withdrawal and blocks reward of smoking. It's a oral, tablet, and previous FDA boxed warning was that many patients fear about psychiatric adverse event, even though they are no more common than with other cessation medications. So not to fear about it, and we have to reassure our patient. The other in the list of smoking cessation medications are bupropion, which we have all used, sustained release, uh, 150 milligram per day for 3 days, and then 150 milligram twice a day, used for 3 to 6 months. Start 1 to 2 weeks before the quit date, and there are some side effects like insomnia, agitation, and so on. So these are recommended pharmacotherapy for smoking cessation in patients with cardiovascular disease. Many of us and our cardiology colleagues are are scared about using these medication post discharge or during an inpatient, but not to fear this as the recommendations go out. Outpatient with stable cardiovascular disease, varenicline or combination of nicotine replacement therapy is fine. There is absolutely no fear. Like the NRT comprising nicotine patch plus patient choice of nicotine gum or lozenges can be used. Inpatient to relieve nicotine withdrawal, nicotine patch or combination NRT can be used even in an acute setting, coronary event, because the dosage that is delivered is hardly anything. At discharge, combination of NRT or varenicline can be prescribed. This is an opportunity for all healthcare professionals to make use of this opportunity and prescribe and counsel these patients. Second line for these patients, bupropion or single NRT product can be used, say, for stable cardiovascular disease. At discharge, single NRT product also can be used as a second line. Third line, there are nortriptyline and bupropions which are used. If a single agent is insufficient to achieve the abstinence, please use FDA approved drugs like varenicline plus NRT, varenicline plus bupropion, bupropion plus NRT can also be combined. So they are quite safe and time tested. So you don't have to fear about using in a cardiovascular patient. Let's move on. So this is how the flow chart goes. Cardiovascular clinician or other professionals and asking about tobacco use status, current smoker, former smoker, never smoker, and assess nicotine dependence, advise, give about how to quit, and offer, connect, and to treatment. And this is all I have explained, but this is a flow chart which is very easy to follow, and continuously monitor these patients, which is important. And don't give up on these patients. For example, more than 1 year since last cigarette smoke, and and uh, and keep following them up like regular patient, once in 3 months, once in few months. And if you have a patient who is willing to quit and unable to quit, you see him frequently, even every 2 weeks can be done. And this is a flow chart which I like it. So here is another flow chart. Former smoker assess the relapse based upon since last smoke. Highest risk, no smoking for less than 1 month. Moderately high risk, no smoking for at least 1 month or 6 months. Lower risk, 6 months or longer. and the treatment options which are all there, and routinely follow up. Again, I'm stressing them 6 months and 12 months, and refer to treatment as as concerned. For example, if there is a relapse, this is from the American College of Cardiology. Current smoker not ready to quit now is also requires some attention, like motivational intervention, rewards, for example, offer medications which are not expensive and if possible free, discuss the use of non-combustible tobacco products, and advise patients to adopt smoke-free home care policies. These are also important. Electronic cigarettes, which are there in the market, very popular among young people, and they like to use them, saying that it has less side effects, and it is very attractive, and you can see the attractive nature uh, of these packages. These are e-cigarettes are nothing but it is not burning the tobacco, it is passing electricity through the liquid nicotine and propylene glycol and a vegetable kind of resin and flavored agent. So this is the e-cigarettes, and there are various forms of it. It's important to know that it is a nicotine containing liquid, and contains chemicals uh, in addition to nicotine, like propylene glycol, I said, glycerin and favored chemical that may pose risk. And e-cigarettes are not currently approved by the FDA as safe and effective cessation aid, and India's cabinet has announced a ban on this production, import, and sale of electronic cigarettes as they pose risk in September 2019. And these are some interventions by the government of India. Cigarette Act, thanks to the lobby to make this possible, legislatures being sensitized and so on, especially doctors who are involved in this. Cable Television Network Act 2000 prohibits tobacco advertising. Cigarettes and Other Tobacco Products Act 2003, COTPA, and 2008 Section 4 of the COTPA, which is specifying the smoke-free rules into effect. So these are some of the work done. And there are also, like any other disease, new molecules in pipeline. The research doesn't stop, and in fact, there are more drugs or molecules in pipeline. For example, exenatine, guanfacine, and D-cycloserine, AZT, and so on. These are all listed, and I haven't read too much about it because these are new molecules which are there in the pipeline, and keep looking for this page in the future. And nicotine blockade therapy, very attractive. Here, reduce or eliminate any rewarding pharmacological effect should the person attempt to resume the drug use. And these are centrally and peripherally acting antagonists like mecamylamine. And these can also be used. I have no personal experience on this, but these are all there. Newer drugs like Nicvax, it works by stimulating the immune system to make antibodies that bind to nicotine molecules. How attractive it is, and making them too big, too big to cross the blood-brain barrier, in turn preventing them from reaching the nicotine receptors and triggering the pleasure sensation that smokers experience and become addicted. In summary, the flow chart for smoking cessation goes like this. And if the patient is willing to quit smoking, yes, no, no, follow up with 5R model which I mentioned, risk assessment, reward, and so on. Follow the 5A model, assess, and so on, which I mentioned about assess nicotine dependence, low dependence, moderate dependence, high dependence. And is the patient willing to use pharmacotherapy? Yes. single agent strategy to start with, and combination, sometimes both may be required. These are flowchart. First choice of agents: NRT, Vernicillin, Bupropion, and cytosine, which is cheap, and I have no personal experience about it. And then the combined one, of NRT and NRT Vernicillin, NRT Bupropion SR, and Vernicillin with Bupropion. All these combination can be used. And please follow up these patients, watch for relapse or failure, and also successful quitting. Many patients send me WhatsApp saying that they have quit 6 months, 1 year, and they're very happy, and they are thankful to me and others who help them to quit smoking. But patients who have relapsed and failure, don't give up on them. That's my take on this. So smoking is a chronic relapsing substance use disorder caused by addiction to nicotine. There is sufficient evidence that smoking has a causal relationship with cancer. Most smokers pass through repeated cycles of short-term abstinence followed by relapse to smoking before achieving long-term tobacco abstinence. Current evidence strongly supports combining pharmacotherapy with behavioral psychosocial intervention as the most effective way to help smokers sustain abstinence. These are, some of the posters you all are familiar with, and the World Health Organization World No Tobacco Day is 31st May. Generally, all of us contribute something or the other that day to the society and make public and the lawmakers aware that smoking is a dangerous, preventable factor in preventing serious diseases. So I stop here. Thank you very much for your patient hearing, and I'm ready to take any question that you may have. Thank you once again. I thank the organizers and my friends in CCI, the secretary, the president, and also the masterclass, masterclass in charge,
Thank you, sir.
Dr. Vijay Kumar Chandam Chetty, for
Thank you, sir,
giving.
for an excellent session. It was so extensive and in-depth analysis and research has gone through that we can see. And I think now we
Thank
have
you.
it is, sir. It is time for the answering the questions from the audience, sir. We have a question from Dr. Fazlul Abidin. He has asked 3 questions, but all of them look similar, sir. And he's saying how to manage smoking cessation in healthcare workers, particularly doctors.
Okay. So, the longest study, Professor Prasad,
Yes.
was about smoking and its ill effects and behavior and so on, was, among healthcare workers, among doctors in UK. And it was done, I think in 70s and, late 80s. And, it comprised of healthcare workers, who were smoking. But I feel definitely it has come down, and many a time I've seen my colleagues from other departments when I'm walking down, suddenly they keep their, the cigarette at the back and then try to avoid. Yes, but yes, yeah, I feel definitely it has come down. But yeah, your colleagues are also your friends, also your patient. So you should consider them and give them advice, take them on the side, and then and treat them like any other patient, and give them, of course, more time and and compassion and so on. But very important. That is one of the barrier for healthcare workers to deal with smokers. It's one of the big problem. I remember one of the very famous cardiothoracic surgeon. He's no more. Who used to smoke and who used to operate on lung cancer patient, was an excellent those days. A surgeon must be very difficult battling this out. but we must take care of our colleagues and healthcare workers. Good question. Yes, it's fortunately I see less and less, as I mentioned in my talk.
Yes, sir. Sir, in your talk itself, you have told that it forms an obstacle. Suppose that someone is smoking in a hospital where we are running a smoking cessation clinic, it forms an obstacle. Sir,
It
next question.
is.
Sir.
It is, Prasad. Also, many a time, you must have heard your friends and others who are smoking saying, "Oh, I know my friend who is a doctor. He also smokes."
Yeah,
So
yes, yes.
that's one real obstacle. But I keep saying he is also a human being outside the hospital, like any other
Any,
in the
uh,
community. Yeah. Yes, Prasad.
sir, next question is role of counseling spouses in smoking cessation from Dr. Shavya Varangal.
Yeah.
So who is the best person to advise, sir? Not only patient, but sometimes we need someone from the family who can take up the responsibility to motivate them. Uh, who do you think is the best person, sir?
Yeah, very good question. Very practical question. How I deal in my, in clinic is I never involve the spouse. Simple reason is they fight. And then she goes on saying, the doctor said, not to smoke, your lungs are 50% gone, you may develop cardiac problem, you may. So, she will, because she's not a professional, she will nag him. And then that irritates him. And that causes tussle between both of them. And then, in anger, he will continue to smoke. So I tell them at home, don't tell him anything about smoking. I will do that. And I will do that. But I, tell them, you can also learn how to empathize. It's a disease. He's not doing it purposefully. He's not unable to give up. And as you know 50 to 70% of smokers want to give up smoking, and it's always there in their mind. So we have to be very proactive and empathetic and help them out. And spouses are dealt in a different way by me. And of course, if somebody can understand what I'm saying, I bring them outside and talk to them, and tell them this is how you should go about it. If he is smoking, don't irritate him. If he is smoking, if you found him smoking outside, don't come back and quarrel with him saying, I saw you on the rooftop that you were smoking and I can smell you. These are some of the complaints that they keep hearing, and they fight, and then nothing happens later. So that is why I tell them, please leave it to the professional. Good question.
But how to monitor them? Like how to do you reassess them by some tests or by like any exhale carbon
Yeah.
monoxide levels, etc. when they come back?
They, yeah, they are there, but I don't do it regularly. Like cotinine levels, for example, in the urine, and these are all mentioned, carbon
Yes.
monoxide and all that. But you have to go by what they say. Best thing is to be very compassionate. And I've never ever got irritated, screamed at a patient. And as I mentioned that you will never quit smoking, and I've tried my best. Now you don't come back. I've never done that. I never give up. I keep talking to them. And even if they come back and say that, doc, I'm not able to give up smoking, don't worry. Don't worry about it. And then you will ultimately do it. And why you're not able to do it is it's a disease. It's a dependence disease, just like alcohol dependence, alcoholism. Similarly, so this they understand. And then many patients have told me that I realize, doc, in your busy schedule, you're speaking to us so much about this, and to make us healthy and to prevent complications which are there. I really feel that you're interested. Otherwise, you could have easily said, oh, it's left you. You do whatever you want, and and the medical profession will have more patients. That's not the point here. So they understand, but you have to be extremely patient here.
Sure. Next question is regarding e-cigarettes, sir, from Dr. Ambika Trichi. She asks
Yes.
whether the e-cigarettes are carcinogenic, and more probably more relevant whether they are addictive. That what are do they cause addiction as
Yeah. So e-cigarettes, as I mentioned, are different. They don't burn. here the electricity passes through the nicotine containing, solution, and then it doesn't burn. There is no smoke here, and it goes through another three glycolin, propylene glycol, and then a vegetable thing, and also there is a flavoring substance in that. So WHO and other agencies have said we don't know the effects of this at all, and right now, but they feel that they are also harmful, and they can also be. I have had some young people, who are addicted to it, and then they say, I'm doing this, this doesn't harm me, this doesn't contain anything which is harmful, so, and but I can't give up on this. Yes, it's one big question that we don't know the harmful effects of it, but they are definitely, even the WHO is saying they are harmful, not recommended for weaning off somebody who's smoking, saying that, as an advice that, a medical professional should say, okay, get into, e-cigarette smoking. No, that's not true. Good question again.
Sir, Dr. Trideep Chatterjee from Mumbai has a question, sir. Do these drugs like nicotine patch or bupropion or similar be useful for tobacco withdrawal, non-smoking tobacco?
Yeah. So, here you are non-smoking tobacco. Here we are dealing with completely a different kind of patient, and they are also used, and especially for non-tobacco, like chewing, gutka, pan, masala. They are also helpful. They are also used, but not extensively studied. That's all. But I have used in some patients, especially bupropion, and not the nicotine replacement, because we don't know much about the usefulness in non-smoking, tobacco. But they also have to be, dealt very severely, seriously, and also require lot of patience. Good question again.
Sir, sir also has another question like any experience of hypnotherapy in helping smoking or tobacco cessation?
Yes, it comes under the CBT and behavioral therapy. Yes, there are various methods. In fact, I have somebody very close to the clinic who is doing this hypnotherapy, and I have tried on a couple of patients because this seems to be attractive to the patient. They feel that, okay, doc, I think you're trying something different. It may be good. I have already tried, NRT. I've already tried your medication. I always say, do something up, along with nicotine replacement, or bupropion or varenicline, and always combine with counseling. Either, I get a counselor in my team. I also have a counselor psychologist, and she's extremely good, and she keeps talking to these patients how to avoid during the difficult and trying times, and also involve a psychiatrist, and in complex patients. But if I come to know that it's easy for me to handle, I will always do that, including behavioral therapy. I do myself, counseling them, talking to them, telling them these are difficult days, go through this, and once you come out of it, and you will always feel nice and good, and many rewards are given to the patient, and given time for these patients, and many a time you can manage without any of those things. But very important, meditation, and some yoga, also relaxation, and these also go a long way. Hypnotherapy, as I mentioned, I have used in some patients, and there are various other methods which are useful in these patients.
Sir, Dr. Soumya from Chandigarh asked that whether this is the best time, like COVID scenario, for telling the patients that this is the best time for them to quit. Can we send a message during this time?
Absolutely. And this, many patients have asked also, what is the effect of smoking and on COVID, and in some instances I have found that they have given up, knowing that pre-existing lung diseases, it can cause serious problems of COVID disease. And some during the lockdown have also increased, telling me that so it's so boring that I can't go out, and then I can't do anything, and then my smoking has gone up now, and I'm tensed about it, and a lot of anxiety. I can't get sleep, and so on. Both I've seen, but as Dr. Soumya asked this question, this is the best time for all of us to keep talking to our patients about smoking. About, if you develop a lung problem, the complications are more. And there are, definitely some studies, which have shown that, the smoking related lung problems, through their effect on ACE2 can lead to more complications like ARDS and so on. There is some article which says that smoking was good, but don't cite all this example that it is good. But
Yes.
show these
Yes.
articles which show that bad, and this is a good time for all of us to counsel patients easily.
Sir. Dr. Mohan from Apollo Hyderabad asks, what is a single important measure that has helped patients in quitting smoking successfully in your practice?
Okay, good question, Mohan. And my personal experience, I'm very passionate about talking. I don't have a separate day for running a smoking cessation clinic, which I did in 90s, very early 90s. But I did it as a kind of social responsibility, or charity kind of thing. I never charged patients, and probably that that led to closing of the clinic, because they thought I must be the craziest man, doing this for free and spending time. I had time, I was not so busy, and very few patients came because they asked me, how much are you charging for this package? I said nothing. And then probably they thought, it may be a time pass kind of thing, and then they never came. And one of my friend, in fact, said, sir, you start having a package and you charge 5,000 rupees, do a spirometry, do an X-ray, and then start counseling. All that I didn't do, but those kind of things probably help. So what I do, coming back to that question, is that every patient I ask, every patient I spend time. Even if I am busy, I take it very seriously. If I'm too busy, I'll ask them and give a time to come back. So every day is my quit smoking clinic, because if you ask them to come again next week or so, they will never come back. So this is an opportunity when they are in the hospital to talk to them about smoking and realize them. And many a time they say, I will come back and talk to you again, but they will never come back. So use this opportunity, have patience, and patient will really immensely thank you. I've had many patients sending me WhatsApp messages saying, this is 21st day, this is 2 months, this is 3 months. And patients whom I have met outside, doc, you don't remember 10 years back you made me quit smoking, I'm so thankful to you. So what is important is your commitment, your passion, and empathy. And this is a disease. Never give up, and saying that, oh, this man will never give up smoking, and I'm fed up of this patient, and he will never listen to me. And they will never listen, doesn't matter, but one day they will. But do your duties and go about it, systematically. Go about it by scientific methods which I mentioned there: pharmacotherapy, behavioral therapy, combination of this, and keep trying. It may take 3 months, 6 months, even 1 year, but ultimately you will succeed.
Sure. Next up, Dr. Vijay Kumar Chinnamachetti first congratulates you on a very lucid talk and asks
Thank you.
how to deal with patients who quit smoking, but say they have been smoking for 20 years and they have stopped for say 1 year, 2 years, but still suppose they come back with lung cancer and then after I stopped, but now I'm having this. So how to deal or what to answer them?
Yeah, good question, Vijay. To be frank, once they quit smoking, 3 months, 6 months, whatever it is, keep them under your follow-up. Tell them that you need, like, as I said, tobacco addiction is a disease. So treat it like any of your COPD, asthma, lung fibrosis, on regular follow-up, once in 6 months, once a year, and then later, infrequently, but keep them under, because there are chances, as I mentioned, relapses are very common. Even after 1 year, 2 years, many a time we have heard after 7 years, 8 years, so I gave up for so long, and then I restarted, something triggered and I restarted. So keep them under your regular follow-up, number one. And to specifically answer your question, that, as you know, it takes 10 years to have that effect. It doesn't immediately go away. Next year your chances of getting lung cancer is not going to go away. It's only 50% after 10 years. So the effects are so long and prolonged, and that is why you must keep them under under your care, and suspect whenever you find that a patient who says, I quit smoking 5 years back, and things like that. But keep in mind about lung cancer, COPD, emphysema, cardiovascular disease. Even then, even though it comes down, but it doesn't go away quickly 10 years later.
Dr. Jay Kishan from Sohana asks, some patients on NRT, they continue to smoke to have a higher kick. Is it or how to tackle with these patients?
Yeah. So, fortunately, the NRT doesn't contain so much as to cause, real harmful effects, but it cannot be continued. So you should discourage them to say that, along with cigarette smoking, to have NRT patches, for example, to get more quick is not ideal, is not good. So you have to keep talking to them about it, that the cardiovascular risk and additive effects can increase. So it has to be done, within 3 to 6 months of starting an NRT, for example. That is why little more time is given, like 3 months, but you can extend. That's what it says. You can extend up to 4 to 6 months, but every time you keep talking to them, telling them, warning them that you can't do both. Either if you are saying that from 10 cigarettes I have come to 2 cigarettes and then using NRT, that's fine. That's fine. You cannot say that I'm still at 10, sir, but I'm also using this after 3 months. That is not going to happen. That is not good at all. Yes, that's one thing that we must all keep in mind.
Next question is from Dr. Vardelli Ramesh. He asked whether the drugs varenicline or bupropion can be used in OSA patients who also have OSA and on smoking cessation. Can without any side effects, can they be used?
Yeah, good question again. We deal with this, day in and out, all of us. Ramesh, actually, varenicline you can use. There are no problems with that. Bupropion also, it's supposed to cause some, depression of the respiratory center. So you use it cautiously, that's all. It's not a complete contraindication, no for bupropion, but use it carefully. If you feel that the patient is getting more drowsier and has headache and then has CO2 narcosis, then you take them off. But varenicline seems to be more safer, and bupropion has some effect on the respiratory center.
Dr. Pujit Chaudhary from Vijayawada has 2 questions, sir. Can social media be helpful in smoking cessation, and how far is e-cigarette a better replacement?
Okay.
With regard to other drugs.
Yeah. Social media, absolutely important. All of us must contribute. Every one of us, from postgraduates to junior to seniors, must write something about the social media on your Facebook or electronic print media. You must come out, and that's why the World No Tobacco Day So I keep saying, World No Tobacco Day for me is every day. It's not just, one day in a year. So you must keep this mind and keep spreading this message. And, during this year's, World No Tobacco Day, I did that. Apart from this on Facebook, and then we also had a chat. We in the Karnataka Pulmonology Association, me, Dr. Amitesh, and Dr. Puneet were involved in campaign, and there were many other tasks that we took during that time. But we should not forget after the World No Tobacco Day is over, and we should keep doing it. A good question. Use social media. Excellent way to communicate, especially with the younger generation, and do that. Always. Coming back to e-cigarettes, it is still evolving, and it is definitely increasing. So we must learn more about it. And in fact, I wrote an article in the paper, and also in our Karnataka Pulmonology Association annual conference, we had a session on that, on e-cigarettes, role of e-cigarettes, and to make other, juniors and others aware of the what is e-cigarette, what is the government's policy on that, what is the international WHO, for example, policy on that, what complications it can cause, and what do we have to convey to the young people who wants to switch over to e-cigarettes because of pressure, because of their own feeling that the cigarette smoking is harmful and so on. So we have to be aware of it, and definitely know and learn more and more about it.
Another important question, sir, from Dr. Jaykishan Sohana. How to set up a smoking cessation clinic, and what actually being done at your place, sir, and what is your experience like? What are the
Yeah.
teething problems, what staff required, the infrastructure required, obstacles faced, etc.
Okay. So, keep it, Jaikishan, keep it simple. Keep it simple, but you have, sufficient number of other colleagues. Like, for example, I have a psychologist, I have a psychiatrist, and of course, your PFT technician and nurse also, can speak. That's what I said in my pro forma. 3 times I asked them about smoking. One, as I start writing the name, age, sex, and so on, smoking, how many cigarettes, and go on probing about it. Then, passive smoking inside, does smoking affect, your asthma? And then when the PFT is being done, the PFT technician will definitely ask, are you a smoker, non-smoker, and so on. So this by then the patient will know that, oh, this is a serious problem that I'm smoking. That's why many of them are asking questions. And your PFT technician also, when he's free, he can speak. So train him. He's a good chap to be in your team, and yeah, so he can start from there. And the nurse also is good, and as I said, a psychologist, who can speak to them, counsel them during difficult times. And of course, I also involve sometimes psychiatrists in my team. But you can keep it simple. You don't have to have a separate kind of an office, and say that this is a quit smoke clinic. But if you do it professionally, it's good. Sometimes it becomes a little impractical. As I said, if you ask a patient, come back next Monday, I'm doing a clinic between 3 and 4 about smoking, they may not come back. And that is one. So when you get an opportunity, use that opportunity, and make use of your time, and give all that you have, and spend time with the patient. But the smoking
Another
cessation will have something like this. And they can also be self-help group. You can also direct them. We have one in Bangalore, and the famous one, of course, in UK is known as the ASH, similar to Alcohol Anonymous that we have here. These are past smokers who have given up smoking and who wants to help others. So if you find someone in your community, in your place, please give them, their address and the phone number, and they're always willing to help.
Few practical questions, sir. How to deal with cessation, particularly in low-income group patients who cannot afford treatment,
Yeah.
and
Okay.
also how to deal with highly addicted smokers, like
Uh,
chain smokers or hardcore smokers, who it is not very easy to give up by for them.
Very true, very true. Good question again, because we should never ignore our rural population, those who come from village, and that is where you see the oral cancers, the larynx cancer, the laryngeal cancer, carcinoma of lung, and COPD, and those kind of things. Never ever ignore, because in villages, smoking is something which is hailed and not discouraged. And people come back and tell you that, when I smoke, I feel good, the phlegm comes out easily, and I can't quit smoking. It's helping me. And so you must educate them, give some time to them. And the cheapest one, I believe, is what is I listed there, cysteine, a medicine which is supposed to be good. I haven't used it. It's supposed to be cheap, but one can try all this, but they should also be given importance. And if they can't afford, but talking to them and spending time with them, will definitely help. I have done that on many occasions and continue to do. I also see a lot of in and around Bangalore, from the villages and districts, and I keep same kind of enthusiasm when I speak to them, and that's what you should do. And the other question was about chain smoker. So here is a difficult
Yes.
patient, and requires a lot of your time and a lot of your patience, and involve now your team, which is psychologist, and which is as somebody mentioned, a hypnotherapist and a psychiatrist as well, you know and the family again is important. Involving the family is also very important here, and talking to the family in a group will help these patients who are very difficult, who are very restless, and then they just can't give up. We've heard of patients after bypass surgery continuing to smoke, after angioplasty continuing to smoke, after a TAO disease, having their limb amputated, but continue to smoke.
Surgery.
We have seen that these are ones I think you are talking, and very difficult. And if I have some, friend whom I don't like, probably these are patients that I will refer to him. Yes. So you really, I mean, frankly, you really require patience and a teamwork here.
Sir, many herbal preparations are available with tall claims. What is your opinion on them, sir? Sometimes patients themselves
Yeah.
ask, sir, can I use those medicines, whether they are available, which are being shown on television, ads, etc. So, do you advise them, sir, or
Yeah. So, Professor Prasad, if they come back and ask me, can I use this herbal thing which is supposed to help me, I will encourage, as
yes,
long as there are no harmful effects or anything, as long as it's not going to take years, you know.
yes.
And I tell them, yes, whatever it takes for you to give up smoking, whatever it takes, do that. It may be counseling, it may be talking to your friend, it may be a herbal, it may be something else, but do it if it suits you and if it is helping you. But if it doesn't, come back, we have some definite, treatment and strategies which are there.
Dr. Hitesh Billa from Vishakhapatnam, sir, he said he observed few people while partying that they wear a no smoking badge. So, how much is useful, sir? He's suggesting whether we should encourage such activities, because we have seen some putting just a no smoking board at some places. helps in people avoid, at least they don't smoke near that board. So can we advise everyone to wear a no smoking badge? And we
Oh,
have also seen that, like, sir,
yeah,
just like there are chain smokers, some people are very much like allergic to smoke. They keep on telling people, even if they see that someone is removing a cigarette from their pocket, they immediately they take offense and they start yelling or screaming, "No, you should not do like that." So, can we take help of those people who are ready to
yeah.
choose health?
So absolutely right, absolutely right. And if somebody is doing that, it should be encouraged, and it's a good idea saying that, I don't smoke, and please you also don't smoke, it affects me, something like that, to convey to others will help. But I always tell my patients, and ask them about secondhand smoking. We should not forget about it. Are you exposed to secondhand smoking? Very important. And uh, and uh, especially, when children are there, with asthma and other diseases, respiratory diseases, as all respiratory diseases in children, upper airway and lower airways are more common if parents smoke. And uh, uh, and I write it, make it a point to write it, that there is history of passive or second hand smoking at home. Immediately they say, this child probably has a grandparent who's smoking, or a, or a parent who's smoking, and they come back and say, no, 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 I don't smoke in front of my children, I go to the balcony and smoke, I go and smoke outside. That is where that third hand smoking, which is deposited on that shirt and on
Yes,
their on the
or
surfaces and so on, that also is harmful. So we must give importance to this also, second hand smoking. And also exercise the government law which is there, which is smoking in public places must be discouraged. And if you find someone, you can even complain, and there is a law, but many of them cannot be enforced because it's India is a huge country, very difficult to go on checking who's doing, who's not doing. But when you find someone crossing that line, you must talk to them, you must tell them about it. And there is definitely a law of the land that you can't smoke in public places. Excellent. These are some things that we must do in parties, for example.
uh, I think we should. I'm going for the last question, sir, because already it has been very extensive. And
Yes.
how to take care of withdrawal symptoms?
How to take care of
Patient put on NRT or other drugs. Withdrawal symptoms.
withdrawal symptoms. So that's very important to write down in your file, what withdrawal symptoms that they have. And also I when I start counseling, I also tell them these are some of the things that you will notice in the first week, you will notice in the second week, and after the third week you start getting better. Nervousness, tremors, anxiety, irritability. So I want family members that sometimes these things happen, but you bear with that. And then maybe even at workplace, screaming, shouting at employees, I've heard from my patients. So these are some withdrawal symptoms, and that is where all our pharmacotherapy helps, the nicotine replacement. And whenever they have in between, that's why if you are using a patch, and whenever they have this urge to smoke because there are withdrawal symptoms, immediately give short acting one, which is a lozenges or an inhaler or a gum to chew, and these will help to tide over that. And you can combine, that's why it's called combined NRT. So a patch which is long acting, once in 24 hours, 7, 14, 21, or a short acting one will help. And also what will help sometimes is a small kind of anxiolytics will help, like for example alprazolam or rivotril kind of medication will also help to tide over this withdrawal. So why people don't quit smoking, and why there are relapses is because of the withdrawal. These can be very troublesome. So listen to them, write down them, that these are withdrawal symptoms this patient has, and it has to be addressed, meticulously and scientifically and through pharmacotherapy and behavioral therapy.
Sure. Once again, thanks, sir. Thanks, Dr. Satish, sir, for an extensive and we must salute your patience, sir. Not only how you deal with the patients, particularly the hardcore smokers and all, but also the patience in answering all these questions. And of course, the lecture was so extensive and followed by a question and answer series, sir. And I thank wholeheartedly from the entire CCI family for your excellent lecture, sir.
Thank you. Thank you.
And I take this opportunity again to thank all the CCI. Sir.
Yeah.
I sincerely thank all the CCI members for patiently listening and asking so many questions and giving more relevance to this masterclass sessions, which are a brilliant idea from our Dr. N.H. Krishna and his team of brains. And I once again thank and say good night to all the participants. Thank you, sir.
Thank you, Prasad, for being so kind in introducing me and also moderating this session. And I
My
thoroughly
pleasure.
enjoyed, especially the question and answer session. There were so many questions, even though it is late night and everyone is busy with COVID work. I honestly thank the full team, the team which took care of technical problems, and Tarun and his team, and also my CCI family, the secretary, the president, and then the founder trustees, and Dr. Vijay Kumar Chandam Chetty, who's the organizer for this. And I thoroughly enjoyed it. And thank you so much. And good night. And stay healthy and stay safe. Thank you.
Thank you, sir. Thank you.